and welcome to today's webinar, Future-Proofing Chronic Condition Management, Blended Care Models, sponsored by Cecilia Health. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC, or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your questions into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the handout section at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. I will now turn the event over to Beth Bierbauer, your moderator. Welcome.
Well, welcome everybody. We are very fortunate to have with us today four amazing individuals: David Weingard, Dr. Barath Tankeville, Dr. Ruth Weinstock, and Dr. Ken Snow. So let's start with a little bit of background on David. David is the CEO and the co-founder of Cecilia Health. He was diagnosed with type 1 diabetes when he was 36 years old and was training for an endurance race. And so David committed to rebuilding his life and bringing positive energy to the diabetes community. He left Microsoft in order to launch Cecilia Health, and Cecilia Health is named after the certified diabetes educator that really helped David get his life back on track. So David, welcome to you.
Thank you, Beth.
Next is Dr. Ken Snow. Ken is the Clinical Portfolio Medical Director in the Transformation section of CVS Health, and his focus is on the advancement of the CVS clinical strategy, where they are trying to help improve the health of their consumers as well as the quality of care that their consumers receive. Now, previously, Dr. Snow was Chief Medical Officer for Neurometrics, which is a medical device company involved in the diagnosis and the treatment of diabetic neuropathy. Dr. Snow, welcome to you.
Thank you. Pleasure to be here.
And then next is Dr. Ruth Weinstock, and Dr. Weinstock is Division Chief of Endocrinology, Diabetes, and Metabolism at SUNY Upstate, and also Medical Director of the Clinical Research Unit. Dr. Weinstock founded the Joslin Diabetes Center in Upstate back in 1995, and it serves people with diabetes in 20 counties across upstate New York. Now, her research over the last 30 years has really focused on the study of finding new approaches for the prevention and the management of diabetes mellitus and its complications, including studies examining the feasibility, acceptability, and the effectiveness of telemedicine, especially for underserved populations of individuals that have diabetes in a variety of settings. So Dr. Weinstock, thank you for being with us today. And last but not least with us is Dr. Barath Tankeville, who is Medical Director of Value-Based Care at Blue Cross Blue Shield of Texas. And Dr. Tankeville is really well positioned to make a difference in the community. He works in tandem with the sales and account management teams, the network team, the strategy team, and the community team all over the state of Texas. And he helps support the company's interactions throughout the state. His role further incorporates physician insights into the creation of the company's healthcare strategy and creating new delivery models such as accountable care organizations. So Dr. Tankeville, welcome to you as well.
Thank you.
All right, well, if you'll allow me to set a little bit of context, and then we will get to the questions. So in the age of COVID-19, providers have really been forced to limit in-person visits, given the susceptibility of individuals with chronic conditions. And providers have really responded by developing telehealth capabilities to be able to supplement those routine in-person methods of care delivery. And the success of this effort really has set the stage for a permanent form of a new blended care model, which can be built for optimizing and improving patient outcomes and for individuals with chronic illness. Now, each of these experts are with us today because they already understand the impact that chronic illness has on the cost of care and the fact that it's a major driver of preventable costs. And COVID-19 has really exacerbated gaps in the care delivery model as people, particularly with diabetes and other chronic conditions such as cardiovascular disease or COPD, have really found themselves struggling with access and affordability to care, and particularly for this chronic illness population, because I think, as we all know, these are the individuals that have been identified as high risk. Now, unfortunately, the incidence of chronic illness is rising in the United States, and it is estimated that 70% of all American adults have at least one chronic condition. And specifically for diabetes, the numbers are actually staggering. We've seen a 26% rise in diabetes costs over the last 5 years. In 2017, it was estimated to be about $327 billion, that's billion with a B, dollars in spend on diabetes. And that is up from $245 billion back in 2012. And it is projected to eclipse $600 billion by the year 2030. We all know that people with diabetes have much higher costs than the average patient, 2.3 times percent higher. And those individuals who are poorly managed with diabetes have costs that are 60% higher than the average. So we will get right to the questions now, and I'm going to ask this question for each of our panelists. Dr. Weinstock, I'm going to start with you and ask you, how would you describe the current state of chronic care condition management in the United States today? And then we'll go to the other panelists.
Thank you. Well, unfortunately, it's suboptimal, to say the least. Too many people with diabetes don't have the education, training, or support they need so that they could best self-manage their disease. Most people in the U.S. are under the care of primary care providers who may not have access to diabetes educators, dietitians, or other team members that they need, and who are forced to have very short visits with patients, so that diabetes is one of many, many conditions they're discussing, and it just can't be given the attention that it might need, given the other comorbid conditions. And also, as people with diabetes are using more technology, there are so many more tools and medications available. Many primary care don't have time, expertise, or experience really to help guide them in this. So they don't have access to the team approach that I think would really help people with diabetes. In addition to the fact that there are many people with diabetes who are undiagnosed, which is another crime.
For sure. Dr. Tankeville, how about your views?
Yeah, so I think it kind of falls along the lines of what she's saying. So it's just really misalignment of not even just incentives, but priorities. I think, everybody here represents a different kind of piece of the healthcare ecosystem, and we all are really good at what we do, but we're not necessarily all aligned appropriately to make sure that we reach the goal that we all actually have is to be the same, but we're working almost against each other in certain ways. And I think that's a significant disservice. And that doesn't just pertain to chronic disease, that pertains to all healthcare. But those with chronic disease are obviously a little bit more vulnerable, and so they just gets exacerbated much more significantly.
For sure. Thank you. Dr. Snow, we'll go to you next, please.
I certainly agree with what's been said up until now. And also, one of the things that I notice is that a significant part of the opportunity of whether somebody with diabetes does or does not get good care is really almost an accident of birth. It depends where they're born and where they live. If you happen to live in a well-serviced area where you have ready access to qualified providers and diabetes education, etc., your care and your outcomes will be much better than if you just happen to be living in an area that is more underserved, where these resources are not readily available, where it's more of a challenge to receive the quality of care that you need. So not only do we know as a whole that we're not serving our population of folks with diabetes adequately, but we also know that we are truly very discordant in where we treat folks and how we treat them, and that there are definitely a subpopulation who are getting the worst of this care.
Thank you, Dr. Snow. David, how about your perspective as a consumer as well as a patient?
Both as a patient and CEO of Cecilia Health, I really feel we're at a crisis in this country with 1 in 3 Americans predicted to have diabetes by the year 2030. In addition to everything that the panelist already shared, which was right on point, we have to realize that everyone is different, and diabetes is a 24/7 condition that doesn't go away. So we need to help people in the language that they need support. We need to find ways to understand their socioeconomic barriers, whether they have access to medications, their geographic patterns, so many things. Are they technology fluent where they'll use an app at all, or do we have to engage with them telephonically at first and teach them how to do this? 25% of the seniors have diabetes. I mean, everything requires such personalization. So in addition to everything already been said, how do we deliver that personalized touch in scale so it could create a meaningful impact?
So, David, why is it that diabetes is so difficult to manage? You started to mention some examples, personalization, so on and so forth. Can you expand upon that a little bit, please?
Sure. So to understand diabetes, to understand that it's really a disease that is influenced by the blood sugar levels in the body. And that means that the insulin that's in the body, which normally would happen automatically for somebody, has to be manually managed by the individual under the care of a physician to take injections of insulin or oral medications or other forms of treatment. So what that means in my case, I'm part of the 5% of the 32 million that have type 1 diabetes. My body doesn't create insulin anymore. So when I eat something, my blood sugar goes up from carbohydrates. When I exercise, it goes down. When I do other things, it changes. But you know what? The only way I can see what's happening is by testing my blood sugar real time or using technology that gives me alerts. And even then, I have to look for patterns and I have to look, what did I do that caused this to go up? Was there a higher fat, content to the food and that delayed absorption? It's very complex. There's a lot of thinking that goes behind this and a lot of analysis, and you really need somebody to guide you through this and train. And a lot of the patterns are not repeatable. You could do one thing a certain way one day and it doesn't happen the same. Now, 95% of the population in the US have type 2 diabetes where there's some form of insulin production. But again, people are overwhelmed. They have enough. They have their jobs, they have their families, they have their lifestyle. And to be thinking about how to solve this every minute of every day and how to integrate it really is a burden that they need support. They need someone to hold them accountable, to teach them the tools, to make sure their medication is optimized. And so it's really complex. It's not just like take a pill and forget about it. It interacts with every single thing that people do every single day. Fitness, exercise, nutrition, lifestyle, it's all related.
Well, thank you for sharing that, David, especially coming from you who have experienced it and really walked in the shoes of your customers. So, Dr. Weinstock, let's go to you next. As an endocrinologist and leader of a provider organization, could you share with our audience the challenges that you and your team have faced in being able to deliver high quality care for your patients? And, what are you seeing is the reality of influencing? How do you provide effective care?
So there are huge challenges. There's a shortage of endocrinologists, and the demand for our services is, quite frankly, overwhelming. It's not unusual for us to get 120 new patient requests a week to be seen. Plus, patients with diabetes are not just seen once, they need follow-up visits, and to see them in a timely fashion is extremely challenging. And in fact, we struggle all the time with just trying to meet the need, which just keeps on growing. We don't have enough endocrinologists, nurse practitioners, PAs, diabetes educators, nurse educators, dietitians, social workers, and mental health professionals, all who are very important to our team to really keep up with the demand. So that is one of the biggest challenges. And there are other challenges as well. Many of our patients have trouble affording both to see us, to see our dietitians, to see our educators. Their plans may limit the number of visits. They may have high copays. They may be underinsured. So they're not getting the benefit of the whole team sometimes for financial reasons. And they can't afford their supplies sometimes. They can't afford their insulins or their other medications. And some of the newer medications, which we know are efficacious, and particularly in people with heart failure or other complications where some of the newer medications may be preferable, they can't afford them. And then there are a lot of barriers for us to see patients efficiently. So there's a lot of wasted time, both with the electronic medical record and with devices. So I'll just say one thing about the devices. The devices are wonderful. I'm talking about the continuous glucose monitors, of which there are 4 now, and insulin pumps, of which there are several, and over 100 different meters. But to download all of them and to look at all that data, which we think is extremely important, and we do it for every visit, look at the insulin data, look at their actual glucose data. There are different proprietary ways of uploading those, and then none of them go directly into our electronic medical record, and it's complicated for the patients to do it. So just getting the information that we need sometimes takes away a lot of precious time that we should be focusing actually on talking to the patient instead, and even getting the people what they need. So our for example, for a number of the devices, the CGMs, continuous glucose monitors, where the companies that we have to deal with, the middlemen, they don't accept electronic signatures. They only accept fax, and they lose the faxes half the time, and they want additional information than they originally said. And it just takes a huge amount of time just trying to get people what they need is another challenge. But I agree that personalized care, the individualized care, is what's really important. So we have the whole spectrum of patients. We have some who are doing beautifully. And honestly, we don't need to see them as often as many of the other patients because they have it, they're in a great regimen, they know what they're doing great. But sometimes the insurance companies want us to see them more often for them to be able to keep their devices. On the other hand, we have people who are struggling, really struggling for lots of different reasons. And we don't have time to go into all the reasons, but they are struggling. And they would really benefit from additional visits, additional support from the diabetes educators and support people, dietitians, as well as more frequent medication adjustments. So what we need is to be able to address everybody differently and not say that everyone needs to be seen every 3 or 6 months. Some people can be seen twice a year, and others may need interactions much more frequently for us to help them, empower them, help them get what they need, and better self-manage their disease. Diabetes is an extremely difficult disease to self-manage. And when people also have other stresses in their lives, it makes it even more difficult.
Well, it certainly sounds like it can be overwhelming, not only for the patient, but for the provider, given all the moving parts. Dr. Snow, from your perspective, why do you think some of the current and past efforts have not been quite as successful? And are you able to share with the audience what efforts you have seen that, in fact, have been successful?
So we know that despite the introduction of all this new technology and despite 8 classes of oral medications that did not exist 30 years ago, so a number of new tools that exist now that did not, one generation ago, we have not seen any significant change in the average blood sugar among folks with diabetes in this country. And so it's not that these tools aren't helpful or beneficial, because they clearly are. But the problem is, as Dr. Weinstock was alluding to, they need to be utilized. And they need to be utilized by providers who are able to assess the issues at hand and what needs to be changed and work with their patients to implement those changes. And so, clearly we have seen, a lack of advancement, so to speak, in the average care going on, partly because of access and partly because this is a disease that requires frequent interactions. And for many people with diabetes, they do not have ready access to a physician, not just from availability, but even if there's availability, how many days off from work can you reasonably take? Can you get somebody to help take you to your appointment? So even if on the medical side of things there's availability and there's access, and we solve that problem, we still haven't solved the problem on the patient side of the equation, that they have to be able to get to their doctor, to be able to access care in a convenient and easy fashion. So that's part of the challenge of why we haven't gotten there. And as for, what are we seeing that that does help? We're beginning to see that directed interventions, either specific programs from provider organizations, particularly when they take on risk for the health of their patients, and can assess who really needs to be seen in what time frame, and frees them up from some of that bureaucracy and really allows them to ask the question of what needs to be done. We've also seen on programs such as in CVS Health, where we have been able to reach out directly to folks and engage them at a retail level, such as a retail pharmacy. We're able to help bring care to them, such as diabetes education, nutrition education, and even lab measurement, in a way that makes it much easier for them to engage. So there's some bright spots here, but we still have a long way to go.
Thank you for that. Dr. Tankeville, you are responsible for value-based care. How does the shift to value-based care, how do you think that that's going to impact condition management, at least for your organization?
I think it's going to be huge. I mean, at least from my perspective, and really to play off of one of the points that Dr. Snow just made, it's really about making sure the financial platform is set appropriately, so that way everyone's benefiting. And just take a step back, providers are obviously doing a great job about engaging and taking care of patients, but to Dr. Weinstock's point also, you've got to customize that. And so right now it's almost built as a one-size-fits-all platform, and we don't allow the leeway from a financial standpoint to make it appropriate and accessible for physicians to reach out to members. So again, providers can reach out as much as they want, obviously, as much as people need it, but at some point they need resources to be able to do that. And we do appreciate that not everybody is a part of a big fancy health system. And how do you help even smaller practices be able to do that? And that really comes to making sure there's financial alignment. And it really comes down to Dr. Snow's point about bearing some risk. Now, that's one thing that's very easy to say, right? Put more risk onto a contract, but that's an actual physician in their practice. That's their livelihood, and we don't want to overburden them with that. So it's that slow transition that's been happening over the last several years, and that's going to continue to happen. That's going to actually set them up, hopefully, for success. And everybody wins, right? The provider wins, and ultimately so does the patient. But those are real small steps. And historically, in this country in the 80s to 90s, when we were in those types of arrangements, there was undue risk on the provider without enough partnership from the payer. And that's what I feel is different this time around. And that's really my role, right, is to actually sit with the medical groups around at least the state of Texas, making sure that we listen to them with feedback like this, and then make sure that we take all the steps that's necessary. One, building that financial platform that incentivizes them appropriately, and then two, what's the data sharing that we can do so they can actually have appropriate clinical insight, so they can know where they might need to do some customizations for certain patients.
Well, for sure, that provider-payer partnership is really, really critical, because both of you want to have optimal outcomes for the patient. Dr. Snow, let me jump back to you for a second. And I know there are some breakthrough technologies out there. Is there anything out there that you're seeing that you think can move the needle on outcomes?
There are, certainly in the world of, for type 1 diabetes, and for many people with type 2 diabetes who are who require complex insulin regimens, the advent of continuous glucose monitoring, they mentioned early in this, the ability to provide real-time, ongoing blood glucose management is key, and tying that in with insulin pumps, where currently you have the information on blood sugar on one hand, the pump being able to deliver insulin on the other, but the human standing in between having to make the decision, which at one level sounds great. Well, great, the human has to make the decision, but there's only so many decisions you're able to make, and you can't spend your whole day practically checking every 5 minutes to seeing now what. And the ability for that to become automated, and what we are now just beginning to see roll out, what we refer to as advanced hybrid closed loop systems, and these will be advanced further with better development over the next few years, where the pump is able to use artificial intelligence to take the information from the continuous glucose monitor, decide on the insulin dosing, and be able to provide it and be able to iterate over the course of time. If they don't quite hit the exact right dose, able to give a little bit more and a little bit more, and maybe there'll be multiple microdoses in over a period of time, so that the pump will actually get the right dose delivered to somebody with far less work on the part of the person living with diabetes, better control and greater freedom from their disease. This could be a real game changer. Now, this is like self-driving cars in a way, and we know where we stand with those. They all sound great until you actually have to, get behind, until you're actually on the road with one, and then you get kind of nervous. So we know that this is really the beginning of this technology change, but the view down the road over the next few years looks incredibly bright. That there'll be a very different approach to management. That results in better care for patients. It results in better outcomes for them. The cost of the technology for those payers who have to make sure that their members can afford this technology can be balanced out by the improved outcomes. So we may be aligning everything in the right direction. And the only thing as I look to Ruth and other folks who are in practice is that more complex technology means that we have even more of an obligation to making sure that the right people are getting either face-to-face or virtually or in some way that they're being connected with those who are able to assist them with this technology.
Beth, if I may, just to pivot off that, or not even pivot, just to add, I think that's a huge point. I mean, we can come up with a lot of technological advances like in other industries, and we do have a lot of catch up in healthcare, but everybody's excited about the catch up and they're excited about any individual product, but we're not really looking at how it's further, marginalizing the relationship between a provider or a doctor and a patient. And I mean, I don't know who's supposed to be paying attention. I think we all are supposed to be paying attention to that. And the physicians really want to make sure it's protected, but they're not always being heard appropriately. And so part of my responsibility is make sure we do hear that and figure out how, when these tech companies or products come and want to be either paid for or figure out how to fit in the ecosystem, we make sure that we loop back and say, well, if your product doesn't really fit with an engagement strategy with the provider, then it's not going to work for us.
Dr. Weinstock, did you want to comment as well?
Yes, thank you so much. So I agree with what everybody has said. Of course, the vast majority of people with diabetes don't use insulin pumps, but the continuous glucose monitoring really has the potential to help everybody with diabetes. And I think, to me, this not only the actual monitors, the sensors, so that people can see their patterns, their blood sugars every 5 minutes, but the ability for them from home to upload to those devices to be connected to a cloud-based system so that we all can look at them. That makes telemedicine and doing remote visits so much more fruitful. The fact that I can now have telemedicine or remote visits with my patients, and we can be looking together at the patterns of their blood sugar. And I can say, well, what happened on that Saturday, or what happened here, and discuss, well, what did you eat, or exercise, whatever the issue is. They can better understand the influences of their blood sugar, and we can better make insulin adjustments. That makes having televisits, honestly, in my view, is just as good as the in-person. Well, in some ways better, and I can elaborate on that perhaps later. And obviously, it's not for absolutely everybody, but I think the ability to be able to see all this glucose data remotely it has really opened up a new world of how we can best manage diabetes and increase access.
If I may.
Well, please go ahead.
I was just going to say that, diabetes offers an opportunity for remote care in a way that many other disease states don't. You can't be a surgeon from a distance. But so much of diabetes is the transfer of information from the patient to their provider, what blood sugars, what you've been doing, what you've been eating, et cetera, moving all that information to the provider, and then the provider moving information back to their patient, with recommendations on medications, on lifestyle, and various things like that. And so, very often back when I was in practice, and as Ruth alludes to, there's many times you really don't need to be in the room with the patient. You don't need to be touching them. You need to be in contact with them. And the more that we can move information back and forth, and the easier that is, the better the care that can be delivered for folks with diabetes. There are still instances where they need to be in the room, but so much of the time, they don't have to be.
David, was there something you wanted to add to that?
Yeah, absolutely. So totally agreement the way you said it. I would package it a different way in the eyes of the patient is what we hear from patients. They want the right content in the right cadence and the way they want to be communicated with. And what I mean by that, the right content for somebody with type 1 versus type 2 or newly diagnosed or not is all going to be different. And so giving that at the right time when they need it, maybe for a mom with kids is when the kids are in bed, or a spouse is watching the kids, or they're not at work. At Microsoft, I used to get these calls during the day and not really helpful during the day, right? So in the evening, so at the right time, and then the way people engage. We find that live interaction over the phone or video is really powerful for the beginning to build trust between the provider and the patient. But over time, some of that can be text and email and, hey, I noticed this pattern. Could you take a look and give me your thoughts, and have more a cadence that makes sense. If I'm traveling and I'm on an airplane and have very little time between meetings, that might be a text message or a link to the dinner I'm planning to eat in the hotel. I don't need a conversation, but other times I'm trying to problem solve. Why did I have really high blood sugars for 2 days? And then I need a conversation. So I think it's that nuance, and the delivery of telemedicine, the expanded since COVID, is just a turbocharge to using technology to really connect really knowledgeable physicians, providers, caregivers like Cecilia Health Team with patients in scale, and for health plans to improve quality measures, lower cost, reduce hospitalizations, lower A1C, improve time and range. All the things that are so important for all these things to come together. Got to keep the patients happy. We got to help the providers have balance so they can cope with their patient populations, improve their quality measures, and the health plans, the same thing. So it's all converging.
Well, that's a good segue because we are in the middle of a pandemic still. And Dr. Weinstock, this is for you. How did you and your team adapt care delivery, and what gaps did you see or threats with the current system?
Yeah. So when COVID hit, actually now we're back in it with another surge, but worse than the first. But we went basically overnight. Within 1 week, we stopped all face-to-face visits and went completely to telemedicine. And that does require new workflows within the clinic, new staff responsibilities. Providers have a lot of training for providers, but also on the patient side. They need to understand, first of all, what we're doing, how to connect with us, and how to do a televisit. So that a televisit's a real visit. Be in a quiet place ahead of time, upload your devices. Now that is difficult. So uploading the devices, for some patients, you can send them written instructions, but I would say for the majority of our patients, that just didn't work, that you need more help than just written instructions. So on the patient side, preparing for it, and also the pandemic came along with a lot of other issues that impact diabetes, people losing their jobs, people not being able to afford food, people not being able to afford medicine, other stresses, uh, grieving. I mean, there are just so many unfortunate aspects to this pandemic that affect all of our patients, and fear. So we were extremely fortunate when we had to make this switch over that the Helmsley Charitable Trust gave us a grant, financial support, so that we could use remote diabetes care and education specialists from Cecilia Health. And I can't tell you how helpful that was. So unfortunately, it just lasted a short period of time. I wish we still had it, but they were able, they reached over 1,000 of our patients, and we targeted the patients who were on insulin, who we were the most concerned about. We thought had the most needs, and they helped them by providing education and support, instructions on how to uploading their devices and get ready for a telemedicine visit, how to deal with stress and diet issues, physical activity issues, problem solving, community resources if they needed it. And they also were able to actually train and start some of our patients on the use of continuous glucose monitors. So that really helped us. We were short staffed. So the other problem with the pandemic is that you're making all these switches, but also some of your staff and physicians are being deployed to the hospital to take care of the needs of the overwhelming number of patients who are now hospitalized. So now the telemedicine itself, once again, we had some experience with it, so we were fortunate in that regard, since we had done demonstration projects in the past. But I could tell you that the majority of my patients absolutely love it. They feel it saves them time. It's more convenient. It's easier for family members to join. They can have their medications there. I have patients who I would ask them to bring their bottles of medications to me, and they never did. But now that they're home, I said, well, go get it so I can see the label. And there were some who were telling me the wrong dose all these years, so I actually know what they're taking. You can see the environment in which they're living. You can talk to family members who otherwise may not be accessible. And even for the older patients who are not as comfortable with the technology, we, would encourage a child or a grandchild, somebody to help them, and that worked out extremely well. Now, and there were fewer no-shows, so we actually can see more patients because they're actually there. We're not limited by the number of exam rooms, so there is an increase in access in that way. We do have our staff room them so that they and prepare them, ask them to do a weight at home if they have a scale or blood pressure at home. Now, for a minority of patients, it is not possible. So the vast majority, it's great, but we do have some patients who don't have a computer, tablet, or smartphone, whose hearing is really poor, or vision is really poor, or other disabilities, cognitive impairment. Some have poor connectivity, and we serve a lot of rural areas, including around the Adirondacks, and some actually don't have internet access. So, there are some challenges for a segment of our population. We did have a limited number of patients. Again, it was a tiny minority, but a limited number who we were allowed to do face-to-face. Although even there, we gave them, sometimes we would give them iPads to use in the room, so there was no one in the room with them at our center because they didn't have connectivity access where they lived, and they couldn't go to their local library, which was closed, or wherever else they might have access to a computer. So I think that it's been extremely helpful. A lot of my patients don't want it. They ask me now in televisits, I hope we don't have to give this up after the pandemic ends. But we may talk about this later. I think that probably a blended model, which is what we actually did when our cases first went up. So in New York State, it started in March. Then it got better over the summer. And we had a hybrid model where we saw some people face-to-face, but others we continued with telemedicine because we still need to physically distance and wipe out the rooms and all that. We didn't want the center to be too crowded. Now we're back in the telemedicine phase. We actually have more people in the hospital now than we ever did in the spring. So, we've been adapting, but I think we all hope that eventually we can continue telemedicine.
Thank you for that. Dr. Tankeville, let me ask you from a payer perspective. What is it that your health plan did to help ensure that your members stayed healthy, and what gaps did you see COVID exposing from a payer perspective?
Yeah, thank you for that. First and foremost, the strategy was to redouble down on our efforts to outreach to our most vulnerable patients or members. We're always in an outreach from a case management standpoint, but we knew that we were going to be stepping into a time period where they were going to be even more kind of isolated from the system. And so duplicating those efforts to make sure we outreach them to help them understand anything they had about what was going to happen or their current conditions with their specific diseases that they were managing, and then answer any questions with regards to trying to obtain any access to healthcare or their medications was the number one priority. Another big one, which is important, is there was a lot of federal and state mandates that came down, and it was incumbent on us to fully understand that, so that way we make sure logistically we followed those rules because they were there to protect the citizens, and to make sure from a financial regulatory standpoint we met those needs. So there was decreased barriers that were faced by individuals to actually receive their care. So that was a big deal for us. And then to pivot from that, insurers obviously have a fully insured book of business where they take on the financial risk, but then the lion's share of what's done in this country is obviously funded off of large employer groups. And so some of the rules could be very different for those employer groups. So me and some of my colleagues spent a lot of time with some of those big employer groups, getting them to understand why some of these regulatory and financial changes are to be put in place. And the things that they had some discretion with, it was incumbent on me as a physician also to make them understand why they needed to remove some of those financial barriers like co-pays, to implement and to make a more robust telemedicine platform that some of the employers didn't really offer. And then the ones that didn't offer it, how could we as the payer, bring on board a telemedicine vendor very quickly, make sure that all the connections worked, and that we educated through the employer group for all those employees to get access to the care. So again, a lot of logistical things that needed to happen, and then also some financial barriers that had to be removed. And two other points that I wanted to make were we obviously knew going into this, we didn't know how long people would be asked to stay in their homes, and access to medications was a big deal. As everybody here usually knows, 30-day supplies are pretty typical for dispensing, but that isn't going to maybe cut it, right, if we're all stuck in home for a couple of months. And so how do we make sure that the employer groups were on board with us being able to open up a 90-day supply for maybe certain medications that we typically wouldn't do that for, because these were unprecedented circumstances. So those are easy statements for me to make, but there's a lot of logistics that have to go on in our back end to make sure all that happens. And so we made sure that happened. And the last one was around, something that nobody ever likes to hear a payer say, but around prior authorizations. But in this case, it was actually for the patient's benefit, right? We know we have relationships with a lot of large health systems that'll have multiple locations, maybe within a city or a geographical region. And many of them made the decision to specifically have COVID patients go to one location versus the other in an effort to make sure that they kept the precautionary measures in place, and a smaller group of people understood how to do those so that you wouldn't deviate from that. But in that effort, they needed to have the ability to transfer current patients in certain locations to other locations. Typically, we wouldn't allow those inter-city or inter-regional transferring to happen unless it was escalating level of care, but we had to remove some of those barriers to say, hey, in this case, it's okay. And then when patients were being discharged from the inpatient down to lower levels of care, like skilled nursing facilities or long-term care facilities, there are very strict criteria that we obviously, put in as barriers to curb costs that are there. We had to remove some of those because we had to make sure that the patients were allowed to move more freely through the system, because we want to overburden the COVID burden they were already facing. So a lot of moving pieces for sure.
All right, thank you for that. David, why don't you wrap up this section by telling us you work with both providers, you've supported providers as well as patients and payers. What are your key takeaways?
The key takeaways are really the patterns we've been talking about. The patient, from the patient perspective, overwhelmed, in denial, isolated, especially in COVID times, need access. 50% of the patients drop off their diabetes medication the first 6 months. So all that from the patient perspective needs to be solved for. We talked about continuous glucose monitoring. That's only 5% market penetrated in the population. So being able to get patients on these real-time sensors, and so we could really create sustainable impact. That's number one from the patient perspective. As Dr. Snow said, the future is bright. So if we get patients in scale on their medications, supporting the providers who have limited time and need support to get through the volumes of patients in a telemedicine environment, we could deliver health outcomes to the health plans that make it easier for authorizations and coverage. That's awesome. So that's one part of the equation. The next step is remotely managing the patient, so we can intervene before the patient's health becomes acute. And all the things we talked about, the devices and the sensors, enable a remote organization like Cecilia in partnership with the provider to be able to do that. And then lastly, to prescribe and titrate, to be able to look at those patterns and be able to say, you know what, I'm noticing these things. Why don't we change the dosage a little this way or a little this way, and make sure that we're working very closely with the patient's provider, so that we're making these changes in a partnership. But we also scale, through a national network of endocrinologists, for example, specialists, because it's not enough. There's just not, 4,000 endocrinologists in the whole country for 32 million people. The math just doesn't work. So we really need to partner and have scalable solutions. So let's get people on the medications devices. Let's start remote monitoring patients to proactively intervene. And then let's really scale access through some of the infrastructure, through telemedicine, and some of the benefits of this unfortunate COVID state. We can make it positive in the future delivery.
Well, thank you, David, for bringing up scale, because that was actually my next question. And Dr. Weinstock, I'll ask you this first. What is it that providers can do to really ensure that this blended care delivery model can be productive and effective moving forward?
So again, I think it's all about individualization, that some patients, are going to require more support and education and training and help from dietitians, from nurse educators. Some will need in-person visits, but many, many, many visits can be done remotely, and that could greatly increase access. That could, with the help of remote educators, education care specialists, primary care can take better care of diabetes. So I talk to primary care physicians and say, have you thought about putting this person on a sensor, for example? And their answer is, I am so rushed, I have so little time. I know they're out there, but it's just too much. I don't know. I want someone else to do it. I want to refer to someone to do it. And there aren't enough endocrinologists, as David said, to do that. But, you don't need actually an endocrinologist to start someone on a sensor. A diabetes education care and education specialist, a diabetes educator, can do that, and can help guide the individual and work with primary care. That is really important. And then you refer to the endocrinologist in the small subset of those patients for whom you've done what you can in that realm, and you feel you need some extra help. So, perhaps more people with type 1 and maybe extremely complex people with type 2, but I think the vast majority of our patients with diabetes, particularly type 2, if there could be a partnership with the primary care and the diabetes educators, with increased access, and it doesn't really matter if they're on site, you don't have them there, and a lot of our rural areas, they just don't exist. But wherever they are, they can be extraordinarily helpful. I was so pleased to see how our patients reacted to the Cecilia Health educators, who they didn't know at all, but they miss them. So I think that giving people what they need when they need it. For some it might be nutrition help, and some people need to take baby steps, so it's not like one visit. So you you meet people where they are. That's there has there many times it's baby steps, and for those of us who've been doing this for many years, we know it's a journey, it's a process. So some people need a lot more visits, and then they get there and they're so happy and they feel so much better, and we know it prevents complications. Others can do well in a relatively short period of time. Everybody is different, as David said. It's a whole spectrum, but being able to give people what they need, I think, um, is what's really important. And as the video platforms become better and people are more comfortable with technology, and I have to say that that's one thing that COVID did. Our patients who never used technology, some of our older patients, they might have had an iPad that their grandkids gave them just to look at photographs. Now they know how to turn it on and have a video visit. They never thought they would do that. So I think people are getting more comfortable with it, and so I think that the possibility of using remote help is, I think, extremely exciting and can really help, many people with diabetes.
Thank you for that. Dr. Snow, I'll pose the same question to you, and you're in a unique position with being both payer and provider with CVS Health. What is it that you think needs to happen to make this blended care model permanent?
I mean, personally, I think it's going to be permanent, even if people didn't want it to be, just because the acceptance, by patients of this much more convenient form and the ability to access care in ways that they didn't want, they're not going to give that up quietly. And as a payer and as a provider, we agree with this move. I mean, this brings care locally to where the patient is. It makes it more convenient for them. It allows the ability to do synchronous care in a more convenient way, and it also allows to do asynchronous care where you don't have to both be at the same place in the same time, or at least at the same time, where you can message with your provider and they can get back to you once, depending on the nature of the question and the information. So I don't think that we're going to go backwards. I think what we need to do is make sure that we put the proper rules and regulations and opportunities in place so that it works in favor of everybody, so that we make it as seamless and as easy as possible for it to continue, so that there's not a huge regulatory burden, so that it's not significantly challenging to providers to be able to offer this kind of care, so that it's not difficult and confusing and an incredible maze that patients have to navigate to make sure that these services are covered, that we as payers try to make this process as simple as possible, making sure that it is not abused, that patients are able to use these services for good, high quality care. And as a provider ourselves, we were already moving towards expanding our electronic offerings in terms of virtual visits and e-health prior to COVID. Ironically, COVID has made it in many ways more difficult to roll this out because there's been so many other priorities going on, but we've still been advancing that because we realize that for all the reasons I said, this is not something that's going to be turning around and going backwards.
And Dr. Tankeville, from also a payer's perspective, how do you think payers should be assembling a portfolio of virtual care providers? What are your thoughts on that?
Yeah, so I'll be maybe even a little bit more brief because they all made great points here. But I think it's, again, goes back to just streamlining our efforts. As a payer, we also have, as I mentioned earlier, a case management arm that reaches out to members. And, if we do it and then the providers obviously appropriately do it, and then we have, companies that are in the case management space that are non-traditional, emerging, also reaching out, it gets very challenging and even more confusing for the actual patient to know who am I supposed to be engaging in for what, right? Forget about the complexities of diabetes. Now I got to figure out, I got information coming at me from 3 different people, and it's not their responsibility as a patient to figure that out. It's really on all of us here on the phone to figure that out. And so how do we make sure that we don't overdo it? So for a small granular example, is Blue Cross supposed to say, no, we find it important to show that we do case management because we need to show that we do it. So we're going to keep doing it, but it might not necessarily be the right thing to do in all aspects. Maybe we take some of those resources and offer it to what Dr. Weinstock said in the early part of this conversation, right? She's got all these needs and doesn't have all the resources. Well, here we are with resources, but nobody wants to talk to us because we're the payer, right? So it's just really misaligning some of the resources, and I think we've got to be better about that. But it takes dialogue like this to actually figure it out. So in my mind, that's core to all of this. Otherwise, we just have great conversations and great ideas, but they never come together properly.
But that's a great segue to my final question. And David, I'm going to pose this to you as the CEO and founder of Cecilia Health. What can companies like Cecilia Health do to bridge these gaps?
Absolutely. Since we partner with the organizations that are profiled on here, both the payer, the provider, the pharmacy, we feel like sometimes we're the glue where we're kind of connecting the dots so that we're all on the same team. We all have the same goals to improve patient outcomes, to help patients. We have the same mission statements, but I think it gets sometimes complicated in mechanics because as we were just talking about. So I think that reach out. Let's help each other. Just raise the hand to any one of us on this call to begin the dialogue, and we'll connect to, deliver telemedicine and scale right now in COVID and in the hybrids that are evolving. B, deliver improvements to quality and lower costs for the health plans, and C, to deliver an exceptional patient experience where patients are delighted not only by the care they're getting, but as we all mentioned in different ways, getting the right content in the right time when they need it the most, in the way they want to receive it. Those are all factors that are kind of converging now, and we're all aligned in our goal. We just have to execute together.
All right. I think we have time for one question, so I'm going to read one of them that came up in the chat a few minutes ago and said, Medicaid and the Blues pay for CGMs and insulin pumps consistently across the board, or will Medicare and Medicaid pay for these things across the board? I guess, Dr. Tankeville, I'll pose that to you first.
Yeah, I can't predict what's going to happen, but I wouldn't see why it wouldn't happen, right? I think a lot of what's happening in this country is the understanding of managed care, right? We've been kind of hinting and talking about this. And so if that's the case, then you've got to appropriately reimburse for all the tools that it takes to get that done. And if people see that that's where the value is, then we've got to get in line to do that. And often, I'll back up. What ends up happening at the CMS level ends up being what we would typically follow behind, especially with a lot of these chronic, very common conditions. Not so much on the more one-off conditions. That's where we get a lot of discrepancy with our regulatory differences. But yeah, long story short, I don't see why that wouldn't happen, but I wish I could be more definitive.
Yeah, just
well,
one
we
thing.
Have come up to.
Sorry,
yes,
I was just going to say that with Medicare, we can look towards a national, basically a national policy regarding everybody in Medicare. The problem is when we talk Medicaid, where each is managed at the state level, which adds an entirely new sort of complexity to the issue of coverage, with each state making decisions, and some of the states now contracting out to private commercial insurers to manage the Medicaid populations, but with stipulations of what will and won't be covered. So Medicaid can be quite a challenging population regarding coverage for anything, whereas in a way it is much easier that Medicare, because it covers everyone nationally, for Medicare, and then for commercial insurance, private payers to be able to align with them. So Medicaid's a challenging area.
Yeah, that's a great point,
Dr.
I think it really comes down to the platform, right? Making sure that Medicare Advantage Medicare does sit on a more managed care type platform. So if Medicaid follows, then hopefully the states will start to realize that's where the financial upside. Sorry, I just wanted to comment on that. It was a great call.
No, No problem. I just want to take a minute to thank you panelists. You've been amazing. You've really shared really important information. And to our audience for tuning in and listening today. I hope everybody has an enjoyable rest of the day. Thank you for attending.
Thank you, everybody.
Thank you all.